This is the first pregnancy video. First, I wanted to go through one of the important notes on UB Learns. In addition to the videos and in-class work with packet and cases, there will be a case submission for case number 4 in the pregnancy packet and cases workbook. The submissions will be done in your groups, and they will be due Tuesday, November 27th at the start of class, not at midnight, the start of class, so we can review your answers prior. All groups should upload one submission for the group and follow the instructions listed in the assignment. As with other sections, there are additional readings, but most of the testable material will come from the packet and cases workbook and our discussion in class. So if you pull up your pregnancy workbook, set up to the similar other packets, objectives and supplemental readings are posted on UB Learns. We'll dive right into the physiology of pregnancy. So fertilization and progression of pregnancy is a very complex process with several different steps, and it results in survival of only approximately 50% of embryos. In order for fertilization to occur, a number of different steps, which are listed there, have to occur in the correct order, and all of the different hormones have to be released at the correct times, as we talked about in the infertility lecture. Some of the definitions as a review: parity is the number of deliveries after 20 weeks gestation, and gravida is the number of pregnancies regardless of outcome. Full-term pregnancies are considered to be 40 weeks, which, as you'll note, from 40 weeks is just a bit longer than 9 months. There are 3 trimesters, and they sometimes also define gestational age. Trimesters vary in the week cutoffs depending on the source that you're looking at, but usually we're looking at first, second, and third. First trimester is week 1 to the end of week 13, second, week 14 to 26, and third, week 27 until birth. Sometimes how patients describe what trimester they're in will help us determine the medication's effect within that trimester, so it's helpful to know the actual weeks. And then medication safety does vary from trimester to trimester based on what's developing within the fetus at that time, so this might not be the same from trimester to trimester for the same medication. So the first thing I like to talk about is determining gestational age. So for patients with a normal cycle, which means it's about 28 days long, the first day of pregnancy is day 1 of the last menses. So this is a little bit difficult to understand, so we'll remind you with the menstrual cycle. So day 1 of the cycle is the first day of menses. This is when conception hasn't even taken place yet, because ovulation doesn't occur until around day 14. But for definition purposes, this is considered day 1. So day 1 of pregnancy is day 1 of the cycle, day 1 of menses. As the fetus develops, we progress through the different weeks. So at the time of ovulation, you're 14 days in or 2 weeks in, this is when conception will occur, and you're actually considered 2 weeks pregnant at that time, even though conception hasn't technically occurred yet. This is how it is defined medically. Early symptoms of pregnancy can include fatigue, increased frequency of urination, and after the first missed menstrual period, that's when some of the other symptoms start to occur as the embryo starts to grow. Nausea and vomiting start a little bit later into the pregnancy. So the first thing we're going to talk about is fetal development, because this is very important in terms of medication use in pregnancy, what's being developed at what point during the pregnancy, and how that medication might affect the fetus. So does fetal stage of development matter? It does. It matters a lot. The risk of harming a fetus at weeks 3 and 4 here, as opposed to other stages, will be vastly different. So weeks 3 and 4, this is a period of division. The zygote is implanted and becomes an embryo, and occasionally during the first 2 weeks, only 50% of those embryos will survive. Because most losses occur early within the first 2 weeks after fertilization, some women might not even know that they were pregnant yet. And spontaneous loss of pregnancy in the latter gestation occurs in about 15% of pregnancies that survive past the first 2 weeks of fertilization. So fertilization occurs here, and then this is really a make or break time. Death of the embryo and spontaneous abortion is pretty common, but again, most women won't even have known that they were in fact pregnant at that time. So this is the point where we would be at 28-day cycle, and either the woman would be realizing that she's missing her period or that she is pregnant. Then we move into the main embryonic period, and this is weeks 5 to 10. Major congenital anomalies are likely during this time, especially with exposure to teratogens. And then the third stage of development is weeks 11 to birth, and this is when functional defects and minor anomalies might be possible with exposure to certain types of medications. So not only does the fetal stage of development matter in terms of medications and what trimester the woman is in because of the different stages of development of the fetus, the pharmacokinetic changes that occur during pregnancy are also important and can affect medications that patients take. So maternal plasma volume and cardiac output and GFR increase by 30 to 50% during pregnancy. So your blood volume actually increases during pregnancy. This lowers the concentration of renally cleared medications. There is an increase in body fat. Body fat is stored for a number of reasons, and mostly for assistance with lactation after delivery. Increased volume of distribution of fat-soluble medications occurs because of that change. There is also a decrease in plasma albumin concentration. Because of that, things that were highly protein-bound will be cleared more rapidly. There's also a number of other changes that are listed here that affect medications, absorption, distribution, elimination, metabolism. So what can harm the fetus? Medications certainly, however, they're actually only about 1% of the causes of congenital anomalies. 3 to 6% of pregnancies may have a congenital anomaly, and 3% of those are considered severe. So causes of congenital anomalies may be genetic or chromosomal. They might be environmental. For the most part, they'll be unknown, and medications will account for a very small portion. I did read something written by Gerald Briggs, who is the maker of Pregnancy and Lactation Handbook and Manual. He stated that uncontrolled diabetes and uncontrolled severe chronic illness are a major cause of teratogenic malformations or congenital malformations. So uncontrolled diabetes could result in 50% of the pregnancies having congenital anomalies, which is vastly different to the percent that medications cause. So teratogens are agents that can cause major malformations of the embryo, and some examples are listed here. Some result in severe changes into organogenesis and structural abnormalities, and some are more causing of abnormalities in the latter stages of fetal development. So those are things like NSAIDs and tetracyclines. There are 3 mechanisms in which medications might be teratogenic or harm the fetus. They can either directly act on the fetus, causing harm or death or defects, damaging the cells, resulting in permanent organ damage, so direct damage to cells. They can alter the function of the placenta, which the function of we'll talk about next, and this causes usually narrowing of the blood vessels that deliver oxygen and nutrients back and forth between the fetus and mother. And then finally, the third type is a cause of muscle contraction in the uterus, which can indirectly hurt the fetus by reducing its blood supply or possibly by triggering preterm labor, which can also be very dangerous. The most common congenital anomalies are neural tube defects, or NTDs, and they are things like a cleft palate, lip, and cardiac anomalies. Folic acid supplementation substantially reduces the risk of neural tube defects in offspring. So most prenatal vitamins will have a certain amount of folic acid within the prenatal vitamin. And then any woman of reproductive age or childbearing potential should be counseled to take vitamins that contain a certain amount of folic acid in order to prevent neural tube defects. Especially women who are taking anti-epileptic drugs, as these medications might reduce the amount of folic acid. They should be counseled to take upwards of 5 milligrams per day of folic acid. And additionally, higher folic acid doses might be indicated in women who have previously had a pregnancy with a child that had neural tube defects, or those that are taking the anti-epileptic drug valproic acid, as this has been shown to cause severe neural tube defects. So teratogens might cause fetal harm. Pharmacokinetic changes that occur during pregnancy might cause fetal harm. So how can we determine how safe a drug is in pregnancy? So first we must estimate the risk. So we have to consider the quality of evidence, how strong it is. Safety data from randomized controlled trials will be what we prefer. However, it is very rare that that type of data is available for pregnant patients, as they're usually excluded from studies. Extrapolation of animal studies is usually not relied upon, and for example, thalidomide was shown to be safe in certain animal models, but we know that that later had very severe effects in fetuses that were exposed to it. Case studies might be another common place that we garner evidence from in pregnant patients, but we have to remember that the birth defect in the case studies might have developed by chance or due to the medication. We're not sure which it might be due to, so we have to kind of take them with a grain of salt. So general principles to consider for drug use in pregnancy include we have to select drugs that have been used for a long time if possible, so we know that they're safe because there's a long record of safety data. Prescribe them at doses at the lowest end of their dosing range. Eliminate anything non-essential and discourage self-medication. So anyone that's Googling to find medications to treat ailments of pregnancy should not be using any over-the-counter or herbal products without extensive consultation with their physician, provider, or pharmacist. And then avoid medications known to be harmful, so those teratogens that I listed before. I'll close this video with talking about the pregnancy categories quickly. So pregnancy categories A through X were categories that used to be available to determine risk in pregnancy. But then in 2014, the FDA made a final ruling that they were going to eliminate those pregnancy categories and that labels should now contain a fetal risk summary, so a summary of all the risk data of the medication to the fetus, all data human or animal, with clinical considerations that explains the risk to women who took the medication before learning that they were pregnant, and any data that's available either in the drug in human or animal studies. So this new ruling applies to all new medications, and then old medications had to update their monographs as well. So people will still refer to these pregnancy categories, and the question you should be asking yourself is, what do these actually mean? Can we black and white make recommendations based on these pregnancy categories? And if you're telling yourself the answer is no, then that's the correct answer.